is Diagnosis Glaucoma with your hosts, Dr. Mona Kaleem
and Dr. Harry Quigley.
Hello, and welcome to this episode on cataracts. Well, Dr. Quigley, what is a cataract?
Well, there's a natural part of your eye called the lens. It's inside the eye. You can't see it normally, but it's right behind the pupil, the round black circle. And that lens, when you're born, is crystal clear, and as soon as you're 20 years old, it starts to get cloudy. Now, as it gets cloudier, that means that you're trying to see through a cloudy thing. Imagine that if you wore eyeglasses, your eyeglasses started getting darker and darker, or you smudged them with your finger. That would be the effect on your vision that cataract causes.
And we should mention that cataract is the leading cause of blindness worldwide, but it is reversible through surgery.
But the reason it's the leading cause of blindness worldwide is there are so many countries where cataract surgery is not available to people because there aren't enough surgeons willing to go after people in big rural areas of India, Africa, and some other large countries. So unfortunately, there's lots of blind people who could be helped if they only had cataract surgery, as those of you listening to the podcast have available to you through our healthcare system.
In terms of how to prevent a cataract, well, risk factors for cataracts are things like age, diabetes is a risk factor, the use of steroids. There are certain medications that can cause a cataract to occur sooner in life. Also, heavy sunlight exposure and smoking can accelerate the formation of a cataract.
Dr. Sheila West and I wrote an editorial a few years ago, and what she did as an epidemiologist was to look at how many cataracts that are presently being operated on because they've gotten severe enough to impact somebody's vision. How many of those cataracts wouldn't have occurred if the person hadn't been a smoker? And the answer was 25% of the cataracts that had to be operated at that time of the person's life wouldn't have happened if the person hadn't been a smoker. So if you need yet another reason for quitting smoking if you're a smoker, this is it.
Oh, wow, that's really a lot more than I thought. Was it any kind of smoking in particular? Cigars, cigarettes?
Well, they were talking mostly about cigarette smoking because that's really the predominant form. The worry right now is that these artificial devices, vaping and other things that young people are doing, are once again getting people hooked. The number of people smoking cigarettes, especially men, was plummeting. And now with the 15 to 25-year-olds all starting up smoking this artificial stuff that they think is cool, we're unfortunately going to see another whole generation of people doing that.
And for those of you who like to be out in the sun, that's okay. Of course, make sure you wear your sunscreen and your sunglasses. You want to get sunglasses that protect you from UVA and UVB light. Something interesting that I read a few years ago was that people in the United States tend to get a cataract in their left eye first more often, and that has to do with the way that there's tinting in our cars. Have you heard that?
I haven't. I would love to see the numbers on that one, but if your favorite sport is baseball, you're in Fat City because a baseball cap is one of the great ways to avoid sunlight exposure. We did a wonderful study that showed that men who work on the water, the watermen of the Chesapeake Bay, the more hours and years that they were exposed to bright sunlight, the more they had cataract earlier in their lives. Unfortunately, a lot of them were also smokers. Not only cataract, and we're not doing a podcast on age-related macular degeneration, but that's the big cause of only partially treatable blindness in the United States. And macular degeneration is also very highly related to both sunlight exposure and cigarette smoking.
Yep, so if you avoid smoking and wear sunglasses or a baseball cap or try to avoid the sun going into your eyes another way, then you're preventing potentially cataract and macular degeneration.
Now, of course, patients are going to say to me, well, doctor, I never smoked and you're telling me I still have a cataract, so how come have I got it? Unfortunately, it's an aging phenomenon in our eyes, and it is, fortunately, as we're going to talk about today, quite a treatable thing.
I like to tell people it's a blessing to get to an age where you have a cataract. So it may not be a bad thing. And again, it's something treatable with surgery. Now, we've already talked about the signs and some of the symptoms of a cataract. When you go see your eye doctor, if your vision cannot be corrected better than 20/40, then that's an indication that you need or could benefit from cataract surgery. Also, if you're having a lot of symptoms, like you're really disabled by the glare, for example, or you're just having a really hard time functioning in some way because of the reduced vision from the cataract, then those are indications that you're eligible for surgery.
We like to talk about it with people by giving examples of their activities of daily living. So I'll say to someone, do you have any trouble reading the newspaper if you still read newspapers, or reading your computer? Or one of the biggest challenges of life is seeing that text running along the bottom of a TV screen these days. And if people are not having any difficulty doing those things, then even if their visual acuity in the office doesn't look like it's perfect 20/20, they're not ready for cataract surgery until major activities of their daily life are being affected, like recognizing your friends or seeing the hymnal number at church on the wall, or being unable to do your personal sporting activities if you're still playing tennis. You'll never see the golf ball after you hit it, so don't tell me you can't see the golf ball anymore.
In terms of the actual surgery, the surgery is done generally in an outpatient surgery center. The procedure takes maybe 20 or 30 minutes to perform. We do the procedures with an anesthesiologist present in most places. Many patients get some kind of medication, either orally or through an IV to relax them, but our patients are awake for surgery. This is nothing to be alarmed about. This is how we normally do cataract surgery. During the procedure, you might hear some buzzing and some humming from our cataract removing machines. You might feel some cool water going in and out of your eye, and you might feel some pressure on your eye.
By the way, that's not the actual water from your eye. What's happening is the surgeon or the assistant or nurse is keeping the eye wet during the operation, and they're spraying sterile solution on the eye, and it rolls down your cheek. So if you think that's fluid coming out of your eye, it's not. One of the most common things that people say is, I've heard that I have to wait until a cataract is ripe. And I guess I've heard that word ripe about 10,000 times. We stopped considering that something had to be ripe to be operated on for cataract about 30 years ago. It used to be that we couldn't take out cataract until it got really bad, and that's why the surgeons would say it has to be ripe. Right now, we can take the lens out of the eye of a 10-year-old kid that's perfectly healthy if we wanted to, if there were some reason for doing that. So it isn't that the cataract has to get to a certain stage of ripeness, it's that it has to affect you in some important way.
That's a very good point. At even an early age, we all start developing a little tiny bit of opacity in our lens, which becomes the cataract. Your doctor might tell you that you have the early beginning of a cataract or that they see just a little bit. And if that's the case, they may watch you for a few years again until it becomes visually significant and you're really bothered. But just because you're told that you have a cataract, it doesn't mean that you need to run out and have surgery.
Yeah, in fact, people will say, well, can I wait too long? Maybe I'll wait so long that you can't get it out. I still have seen patients who were told by another surgeon, well, we better get it out now because it's going to be harder and harder for me to get it out later. Now, in fact, there are cataracts that are very late in their development that it takes a truly experienced and good surgeon to do that safely. But I would say 95% of cataract, you can wait as long as you like, and you would have the same good result if you did it tomorrow or 5 years from now. So it's up to you to make that decision with your surgeon as to when it's time. But ain't no such thing as ripeness anymore.
So here's a question. Do you have cataract surgery in both eyes on the same day?
You know, that is done in a few places. I think that the vast majority of surgeons prefer to do just one eye at a time. Because if something happens, and it's rare, but if something happens that delays the return of your vision, and if that were to happen in both of your eyes, you might be unable to care for yourself, to feed yourself, to go to the bathroom and do other things, with both eyes having been blurry for some period of time. Or, God forbid, the really unusual bad complication, maybe an infection that could happen in both eyes. I think if I were having cataract surgery, I'd want to have it done in only one eye at a time.
And how far apart should they be spaced?
Well, I think the soonest that you would do it is when the first eye is able to be proven to have had no troubles and to be useful for getting the person along. Now, that can be as soon as a day or two. There are many people who, by a day or two later, they're reading the newspaper and playing golf. It is more common that it's 2 weeks, 3 weeks before somebody really settles down and has pretty stable vision. And remember that you're probably going to be wearing eyeglasses after cataract surgery. We'll talk about that in a minute. If you really need a new eyeglass, you may wish to wait until you have that new eyeglass put in the frame that you have now. Don't let them sell you a new frame unless you happen to want one. And then with that new lens in your eyeglasses in front of your cataract operated eye, you can go ahead and do the other eye. I would say the average, what do you think, Mona? 6 weeks, 8 weeks between surgeries? Or how long do you wait? You do a lot of them.
Well, I always tell people if both of your eyes are ready, I would wait at least 2 weeks in between as the minimum amount of time to wait between the surgeries. But it's really patient dependent. Some people want to wait longer, which is totally fine. This is nothing urgent, but at the minimum, I would say 2 weeks.
There are a couple of other very minor but still important things. One is that most surgeons, certainly we at Hopkins, ask your medical doctor to give us a clearance to tell us that you haven't had any recent acute illnesses. Now, if you do surgery and you get that from your doctor and then you wait, let's say, 90 days, our anesthesia people might say, oh no, they've got to go back to their doctor and get another clearance. So there's some value in doing it relatively closer spaced so you don't have to repeat some of the preoperative things.
That's a great point. And right after the surgery is done, you'll get an eye shield and sometimes a patch put over your eye for a few hours. You'll be able to see the same day when that patch or shield comes off, and you will be using eye drops for a few weeks after the procedure. They're healing eye drops. One is a steroid eye drop, or a nonsteroidal can also be used, and an antibiotic eye drop. Every doctor is a little bit different in what they're going to prescribe for you afterwards, but those are generally the types of eye drops that are used. The postoperative course, I would say, is about 4 weeks. As mentioned, you'll be able to start seeing the same day, but over the course of about 4 weeks, that's when you're going to be tapered off of these eye drops. And generally, in about a month is when you'll go to your doctor and they'll do something called a refraction and a dilation to see what your final vision is, and also to take a good look at the back of your eye and make sure that there's nothing going on in the back that could be obstructing or causing you to have a worse vision outcome than expected.
And there's a thing called monovision, which shouldn't be confused with a monorail. A lot of people say, well, can I get away without wearing glasses after the cataract surgery? And here's the problem. Once you reach the age of people who have cataract surgery, you've probably begun using bifocal glasses or progressive bifocals because we lose the ability to change the focus of our eye with time, so that we need an eyeglass for the distance and an eyeglass for near. And with the progressives, you also have the intermediate distance lens power built into the middle of the lens of your eyeglass. Now, there have been lenses to be put in at the time of cataract surgery, and we always put some kind of lens in the eye to replace the lens that's there. Some of those lenses are just plain single powered lenses. In fact, that's probably the most common thing that's put in. And it's what Medicare pays for, it's what insurance pays for. And in that case, you have the lens put in your eye and hopefully have a really minimal eyeglass for either far away or for up close, but not for both.
So what Dr. Quigley is talking about is the lens that we put in your eye. So I mentioned earlier that we use a machine to crack and to vacuum out your cataract, and then we put that new lens implant in your eye. And how we determine which lens you should get put in your eye depends on, well, what you want. So if you tell your doctor that you want to be corrected for distance vision, then they'll put a certain power kind of lens in your eye. But I know some people, they like to wear glasses for distance and they want to be able to see really well up close.
Like sitting in bed at night and reading without your glasses on. And that's me. I'm mildly nearsighted. I love to sit there at night, take my glasses off, and just read bare-eyed. But in that case, if I were to have cataract surgery, I would have to have the surgeon make me nearsighted. So I would need glasses for far away. And the truth is, I would still be wearing bifocals. And the truth is, most people still do wear bifocals. But you can do something that some people do before they have cataracts with their contact lenses. They wear one contact lens for near and one contact lens for far vision. President Ronald Reagan, I was involved in taking care of him, and he did monovision, which is why you never saw Reagan wearing glasses. And if you do that, and you've done that before you have cataract, you might say, well, why don't you fix me like that with my cataract surgery? And we'll make my right eye my faraway eye and my left eye my near eye. That sounds good, but you better really want that, because once it's there, it's there. We very rarely change the lens inside the eye. There's a possibility of trouble if you try to go in, and you can do it, but there's a possibility of trouble if you have to go back in and change one lens for another. And so you better be sure that you want this monovision, one eye distance, one eye near. So there's another alternative. What's that?
Well, that's called a multifocal lens. So there are some lenses that can be put in your eye that will correct you for distance and for near. They are not covered by insurance, so you will be paying out of pocket for them. And there are pluses and minuses of these lenses. I would say that I know people who have had these lenses put in their eyes, and they're troubled by issues like glare at night when the pupil dilates. But there are other people who love having these lenses in their eyes because they don't have to wear glasses at all. So if you are interested in a multifocal lens, talk to your doctor about the pluses and minuses of these lenses, because as Harry mentioned, once the lens is in your eye, it's not that easy to replace it.
And then there's the ones that are to correct something called astigmatism. And the short name for that is toric lenses. Astigmatism means that instead of your eye being shaped like a baseball, it's shaped like a Quaker Oats box. In other words, it has a different curvature vertically from horizontally. And we normally correct astigmatism in your eyeglasses, and you may not even know that you ever had that. But if you have a bunch of astigmatism, if it's pretty significant, there are lenses that can be put in that correct both directions, both the vertical and the horizontal direction. The surgeon has to be very prissy about putting it in exactly the right orientation. And once again, you pay out of pocket a bit for these because standard insurance says that's a luxury item and you have to pay for it. I would say those are, generally speaking, a bit more successful overall than are the multifocal lenses, the ones that try to get rid of lenses entirely. Do you think that's true?
I do. I think for myself, I would want to get monofocal or monovision personally.
Yeah, as it turns out, I think there are people, though, who get everything set up fine. And I vividly remember my mother-in-law, who lived to be 95 years old. And she had her cataract surgeries really well before that, in her early 80s. And everything was fine. She saw beautifully at distance. She wore reading glasses, but then she said, oh, I've always worn reading glasses, so I don't mind doing that. And then about 5 or 6 years after the surgery, she said to me, Harry, this surgery stopped working. I said, what do you mean it stopped working? She said, well, now I can't see at distance unless I get glasses. What happened? I said, well, you aged. The degree to which you need eyeglasses depends upon the length of your eye and the shape, especially of the front of your eye, the cornea. And those things are not static. They change over time. So unfortunately, people who have cataract surgery and everything's perfect in year one, if you live 10 more years, it's likely that things will have changed. Your vision will still be absolutely correctable, but with glasses of a different type.
I did want to mention something called femtosecond laser, which is newer technology that is used in some cataract surgeries. Some doctors will offer this. I personally don't do femtosecond laser. I don't see a huge benefit to it. It does cost out of pocket. What the laser does is it assists the doctor in making the opening in the capsule of your eye. Again, I'm not a fan of this, but I don't perform this procedure. Do you have any thoughts or opinions on it, Harry?
Yeah, somebody said it's $1 million thing that could be replacing a 10-cent needle. We normally make the initial step of the laser by coring out the front surface. Imagine that your lens of your eye is a grape, and you know a grape has the skin on the outside and the gushy part on the inside. So to get in there, what we have to do is make a circular cut in the skin of the grape, remove that circular cut, and then go in with a vacuum cleaner ultrasonic vibrating instrument, the phacoemulsifying unit, and remove the interior gushy part leaving behind the thin capsule inside which the new lens is placed. So all this femtosecond laser does is make the initial hole for you and maybe very slightly liquefy the laser, but then you still need all the other steps that normally would have happened. So people say, well, I want my cataract taken out with a laser. You can't have it taken out with a laser. You can only have one step of it done with a laser. And there's no study that shows that that's actually going to give people fewer complications or better vision. Yeah, I'm not against using it. I mean, the Wilmer Institute has one. Some of our surgeons use it. I think they generally use it because people have heard about it and say, I want to have that new laser. And so the surgeons are willing to do it for them because it doesn't have any downside risk except the cost.
I agree with you. I haven't seen anything to date that proves that the outcomes are definitely superior using that laser. So I caution everyone to be careful when you talk to your doctor about the options, like the add-on options for cataract surgery. Let's talk a little bit about the benefits and the risks of the procedure. So benefits are, of course, to improve your vision, improve your ability to perform certain activities that you might be having a hard time with. There are risks also, intraoperative risks and postoperative risks. Intraoperatively, we always plan for a good day. Sometimes things can happen during the procedure. For example, when we're trying to remove the cataract from your eye. This is the way I describe it, Harry. I don't know if you have a different way, but I tell patients that a cataract is like an M&M and inside there's the chocolate. And so we're opening the top part of the shell and vacuuming out that chocolate. Sometimes there's a crack somewhere in the shell and a little piece of the chocolate or the cataract can fall to the back of the eye. If it's a small piece, it's generally okay. It can be absorbed by the eye. But if it's a big crack and a big piece falls, then a person may need to have a second surgery down the line performed by a retina specialist.
Yeah, I think you're a candy person and I'm a fruit and vegetable person. I was using a grape analogy and yours is an M&M. I love that. I may switch to M&M actually. If you look and see how often during cataract surgery by people who've done 100 or more cataracts, how often does this losing the integrity of the surgery, having a piece drop into the eye, breaking open the skin or capsule, how often does that happen? It's probably 2 or 3% of the time in the hands of serious surgeons. Now, of those people, many of them still have great vision and don't experience complications. But of the few complications of cataract surgery, they become much more common if the capsule is violated or if there's a piece left behind, especially with regard to swelling in the retina part of the eye, which can be treated with eye drops, can be treated with even injections of material into the eye later on if it's very severe. But sometimes that does lead to non-ideal vision. And so we all strive for the 99% successful, non-complicated cataract surgery. Some persons are a little more likely to have that thing happen. In fact, as glaucoma specialists, we see people who are much more likely to have those kinds of problems because the glaucoma type that I'm talking about, it's known as exfoliation, leads the capsule to want to fall apart in the middle of the surgery, or the whole lens to come loose and not be attached. This M&M, or grape, is actually attached by little fibers. It looks like a trampoline. You know how a trampoline has those little springs that attach it to the outside frame? Well, in these people with exfoliation, they get a looseness of these fibers that hold the lens in place. It's called the zonule. And you've got to do some fancy stepping in surgery to get in and out of the eye of somebody with exfoliation. So we like to joke with our cataract surgery buddies that the best cataract surgeons are those who take care of glaucoma because we have the more complicated cases.
We should also mention floppy iris. So floppy iris is something you as a patient, you won't notice it, but we notice it when we're doing surgery. So when we do the surgery, we dilate your pupil, and so your iris is pulled back so we can see the cataract well. Sometimes your pupil or your iris bounces around, and that can often happen if you're someone who takes a medication called Flomax or tamsulosin. Another medication that can induce this effect are things that are alpha agonists. So if you're taking a blood pressure medication, which is an alpha agonist, or you're taking Flomax or tamsulosin, talk to your eye doctor, let them know what you're on, and go over your medication list with them.
Yeah, the Flomax is mainly for humans with a prostate gland, so you ladies are off the hook, but not on the second alpha agonist group of medicines. And if the surgeon knows ahead of time that you're using those medicines, they may actually find out if it would be safe for you to stop it for a period of time. The downside is that once you've used that medicine, it probably is going to have this effect on the eye for a couple of years afterward. And so the surgeon simply needs to take some extra precautionary steps. And that tells you that there's an awful lot of preoperative thinking and planning that any surgeon goes through, especially if you have one of these conditions like exfoliation or potentially a floppy iris or any form of glaucoma. Because as we're going to tell you about in future podcasts, we sometimes pair up cataract surgery with glaucoma procedures done at the same time.
Other potential complications that can occur postoperatively are things like uveitis, which is inflammation of the eye. Uveitis is just our fancy term for that. Swelling of the cornea or corneal edema can also occur. And it's pretty rare, but you can also get an infection called endophthalmitis. These are things that are all very treatable, but they're things that you should be counseled on as potential risks of any eye surgery. These are all more short-term risks. Long-term risks can include things like Harry just mentioned, swelling of the back of the eye in a place called the macula. People who have a history of diabetes or have a history of inflammatory eye conditions are more prone to that swelling in the macula. Another thing that often happens is a posterior capsular opacification. I'm sorry, I shouldn't say often happens, but can happen. So, Harry, do you ever get the question from patients, hey, when you do my cataract surgery, is that it, or will I ever need to have cataract surgery again?
Yeah, does my cataract come back? And the answer is no, the cataract per se doesn't come back if you removed it all. But remember, as I mentioned, we leave behind this skin on the M&M or a skin on the grape, and that's called the capsule. And for the first 2 to 3 months after the surgery, the new lens that's put in is spring-loaded with two little arms that hold it in place. And after a while, a couple of 3 months, it's pretty well locked in place. It's not going to go anywhere. It's not going to move. But the capsule behind it can start building up some opacity. The reason for that's kind of complicated, but it's happening less and less and less as we get better and better at doing phacoemulsification cataract surgery. That is the standard type that's being done. But I would say still overall 10%, 15% of people within 1 year to 5 years to 10 years after their cataract removal, the capsule starts fogging up. Now, your eye doctor is going to continue seeing you, we hope, at least once a year. And what you would notice as somebody whose capsule is getting opaque is that your perfectly clear vision starts to get cloudy. And you're not seeing as sharply as you were seeing before. Or you're being bothered more by glary lights than you were being bothered. When those things happen, it's absolutely fixable. It's an outpatient thing with eye drop anesthesia. It's done with a laser in the office that every cataract surgeon, every glaucoma doctor has in their office. And we just simply make a hole in the capsule behind the new plastic lens, but without letting the new lens dislocate.
That laser is called YAG, Y-A-G. So you may hear your doctor talk about doing a YAG on you, and it's referring to the laser to remove that opacity that's formed on your lens. I'll often use the analogy of like a cobweb that's formed over the lens, and I'm just cleaning it off with the laser. Another potential side effect that you should be aware of from cataract surgery, well, it relates to photosensitivity. So as a cataract grows in your eye, it has yellowish hue to it, and so you might not actually be seeing colors as brightly over time. When you have the cataract removed, it removes that occlusion, and so actually you're seeing things much more brightly and colors might seem more intense. I've had a few people complain about that blue in particular was very bright. So that is something that is kind of a double-edged sword. It might take some time to get used to and to adjust to that, being able to see colors more brightly again.
Well, the people who have fun with this are those who have one eye cataract done, and then for one reason or another, they don't have the other eye operated. Let's say one cataract can be well ahead of the other one and bothering you, but the second eye doesn't have a bad enough cataract that it bothers you. So now you look out at the world with your lens that's the native lens that's getting older but still okay, and the perfect clear plastic lens. Well, the eye that sees from the clear plastic lens sees a lot more of the true blues in the world, whereas your eye that's getting the aging lens, the aging cataract, doesn't see blue. And so the two eyes are seeing the colors of the world differently. When you have the cataract removed, you'll find out that what you thought you had was a black dress turns out to be navy blue. Also, if you're an artist, and I've operated on quite a number of artists who tell me that all of a sudden their watercolors now, they just love adding many more blues to the watercolor paintings that they're doing.
So the bottom line is that cataract surgery is safe. Many of us will need it in our lifetime. And just know what you're getting into. Make sure that you explore the different options with lenses. Make sure that you're informed on the benefits and the risks. And talk to your doctor and think about it yourself and discuss with your family about when is the best time for you to have that surgery.
We might throw in one more thing, and that one more thing actually falls into, would the cataract be okay if you have glaucoma? And not only is cataract surgery okay if you have glaucoma, it's just as easy in most glaucoma patients, but it actually can benefit the eye pressure. And now with 2 or 3 important studies that have looked at this question, we now pretty much expect that the control of the eye pressure for a glaucoma patient might very well be benefited by the cataract surgery alone. And so you'll be talking to your doctor about that as it comes time to do the cataract surgery if you have glaucoma. There's even a small chance that you'd be able to decrease the number of daily eye drops if you had cataract surgery.
All right, and that is a good teaser for episode 16. Stay tuned.
Thank you for joining us. Until next time, your mom says take your drops.